Again, very good evening, one and all. So, Nandini ma'am, shall I just start introducing you? I think, I don't know whether I'll be able to introduce you properly or not. So sorry about that. So, Nandini ma'am.
Sure, Vinila, let's start. Yeah.
Thank you so much once again. Very good evening to one and all. This is Vinila, the program coordinator from Hyderabad for palliative care. So I should say that it's really great pleasure to introduce Dr. Nandini Vallath. So I'm a big fan of her, to be frank. And Madam is a very senior most palliative care faculty. Madam, whenever we do teaching sessions in Hyderabad, Madam used to come and teach many students. And I have worked with Madam, I think, for the past over 13 to 14 years now. I have known Madam, and it's really a pleasure to have you here, ma'am. So just to give you a bit of background, ma'am, I'll just introduce you and hand it over to you so that you can introduce yourself more rather than I introducing you. I'm so sorry. So Dr. Nandini Vallath, Madam has done her MD in anesthesiology, and Madam also has done her postgraduate diploma in palliative medicine through Cardiff University from UK. And Madam is a very known international fellow in pain and policy, which Madam has done from United States of America. So, ma'am, thank you so much for giving your valuable time to us and trying to spend time with our participants. And just to give you a bit of background. So we have actually 40 to 45 participants, ma'am, who have actually registered for the session. But due to this COVID duties and hectic workload, for every session, I see only under 30, the participants only under 30 who are able to join. And usually we share the recorded YouTube link and share it with them so that later on they can read. And once we give the question and answers, if they can listen to that and read it, it will be nice. But we have 20 doctors and 20 nurses, but here I see if we remove the faculty, there are only 20 participants now, and now it's already 7:10. I think we should not wait. So I hand it over to you, ma'am, and please feel free to introduce yourself once again. I know I have not done justice for your introduction, but still, thanks a lot. Over to you, ma'am.
Thanks a lot, Vinila. As usual, you are always very kind. So let us not spend even one more minute on introducing myself. I'm just here at the bequest of the MNJ team. And let's get on with the theme for today. That is medical ethics as relevant to giving palliative care to patients in need. So before starting my presentation, I would like to know, average, most of you are medical or non-medical participants? Vinila?
All of them are medical participants, ma'am. Either they are staff nurses or the doctors,
medical doctors. Okay, so there are nurses and there are doctors. And all of them work in Andhra Pradesh, Telangana area, or all over India or other places?
Sorry, ma'am, I think I missed telling you this. All these participants are doctors and nurses working as nursing officers from northern province of Sri Lanka, ma'am. So, yeah,
okay.
northern province of Sri Lanka. Okay. They're working in different hospitals. Like I think I heard that there will not be Sri Lanka and there will not be any private hospitals, and everything is like a government hospital. So all of them are working in one of the government hospitals, and they wanted to give a background. Way back, we have 4 doctors and 4 nurses who have all the way come to Hyderabad and have done 6 weeks of training, ma'am. Last 2 years, because of this COVID, we are not able to do the physical training, and we have started this 1 month, 6 months course now, because we are doing it only weekly once and 2 hours session, and it's going to be 6 months of the course, ma'am, certificate course with University of Jaffna, Northern Province of Sri Lanka, and Hyderabad Center for Palliative Care. And all of them are very new to palliative care, ma'am.
Great. Okay. Thanks a lot. That's very helpful to know. And I think you had mentioned this about a few months ago, but I was not sure. So some of my contents are relevant to Indian law also, but we could discuss that out, and we will try to understand mutually the relevance of those points in Sri Lankan law. So today, let me start the discussion for today. That is, I hope you all are able to.
I think something is coming up, ma'am. Ma'am, are you comfortable in Tamil also? Sometime in between, if possible.
One sec. Are you able to hear me?
I can hear you, ma'am, but not able to see the screen. It says
okay.
started
Yeah,
screen
so I
sharing.
can manage little bit of Tamil if. Okay, I'm just, I don't know, somehow my computer is looking like it is stuck. I will. So it didn't share at all, right?
No, ma'am.
Okay. So 1 second. Let me try again. I hope I am the visible.
Yes, ma'am. Perfect.
Okay.
Yeah.
All right. So
we also
this
have
is
just to give a bit of background, ma'am. We also have Dr. Daniela here. So, madam is a clinical professor from Canada. So, the next session is by madam, but madam is going to stay for the throughout session. Thank you and welcome, Daniela. We'll introduce you once again.
I didn't get Daniela is from where?
From Canada, ma'am.
Okay. All right. All right. So today's topic, although it is being presented to all of you as part of palliative care, I'm sure the approach to ethics and its application may be of use to you in any of the clinical scenarios that you may find yourself in. So hopefully, I wish to have an interactive discussion. And the overall topics that we would be looking at, I don't know how much we will cover, but this is the plan: the cardinal principles of the ethics, proportionate care, the doctrine of double effects, ethics, and the Indian law. And from there, we could, look at what is there in Sri Lanka. And then there are some areas of controversies like sedation, nutrition, hydration, etc., and any other topic that you will bring up from your experience as clinical professionals. So would you be able to unmute and say what do you all think about morality, law, and ethics, so that we get an idea of plunging into this topic? So would you want to just unmute yourself and say something about what do you understand as morality, law, and ethics? If you don't volunteer, I'm going to just call you out. Dr. Paul Bright. Let me start with the bright star of the team. What do you think of morality? Please unmute yourself, Dr. Paul. Yeah, thanks.
Morality.
Just an overview idea, that's all.
Being up in safeguarding our integrity to ourselves,
okay,
thereby doing the just to the patient and others.
Okay, morality, the patient, others don't come. Like what you said in the beginning, right? What we feel right to be done, right?
Right.
Law. Anyone would like to say from what he says? He says to preserve the value for ourselves is morality. Would anyone want to say what does law do based on morality? Is there any relationship between the two? Dr. Puvikaran, can you try and guess what do you think about the relation?
Law is we have to follow what is already in paper or whatever.
Okay, so there is a system which is documented for sort of protecting and preserving the moral values of the society. So it stems from the morality of individuals, which affects the the values of the society, and then there is a system created to protect those values. Correct? Now, where does ethics come? So Dr. Bright mentioned it in his thing, but so medical ethics, it's again an extension of these two. Law is for the general society, whereas medical ethics are guidelines for professionals when we engage with human beings, because our work involves human beings, so their morality comes in, the societal norms and laws come in. With that, the right practice and what we value in our clinical work matters. So with that background, let me go back. So as just to summarize, morality is generally at the level of, we talk about it at the level of individual behavior. And this will, of course, determine the societal culture and vice versa. Like, for example, what someone needs to wear, a burqa or, micro mini shorts. What is moral depends on the societal culture of that area, right? Something may be absolutely acceptable and moral in, say, Europe, may not be so moral in Saudi Arabia, for example. Both are completely different. Then law is a system to protect the values of the society. So obviously, the consensual determination of the society will determine their law. Something which is going to cause a death penalty in one place may not be a penalty at all in another place. For example, a divorce or someone having extramarital affairs, etc., could be a huge moral issue in some parts of the world, and it may not be such a big issue in another part. And ethics is, of course, we are all medical professionals, and so the guidelines governing the values of our decisions and practice would be ethics. Shall we go ahead with that, so that this sort of paves the background for what we are going to discuss? So based on that, we need to also understand that there will be divergence sometimes. The individual morality may clash with the legal systems. For example, it may be okay to do medical termination of pregnancy by law, but it may not be okay by the individual. So it is not that they are all watertight. They may be conflicting, and there may be contradictions. And what we may think as absolutely okay for myself may not be so okay when we think of somebody else's point of view. So that is the reason there are lots of ifs and buts in this whole discussion. So there is nothing like a absolutely right answer. And so please, I would request you to interrupt me as I am going through these different aspects of what I plan to discuss, and ask those questions which are like irritating you, and you don't accept something that was told, or you want to add to it or something. Please feel free to interrupt. All right. So there are some principles when it comes to, because all these morality, law, and ethics, everything is because of the societal nature of our living. We are social beings, and so the whole society runs on some basic principles, which are trust, respect for life, and respect for the person. I've taken these especially because we are talking as medical professionals. And so let us look at what do we mean. Now I will be talking more about the medical aspects of whatever we began with. So trust, could you make some guesses? I would like you all to sort of, say, how does trust come in our medical practice? Where do you see it reflected? Trust between human beings as the basic fabric when we are working with our patients or with our colleagues, or
when we are taking the history from the patients.
Yes.
If the patient trusts on a doctor, if the patient think that it might be confidential only, they will disclose the facts.
Very nice. So therapeutic relationships are based on trust between patient and the doctor. So the very important word that he used, that is confidentiality, is one of the basic tenets of our practice. And patients will we will be able to help the patients best when we develop therapeutic relationship. Anything else that you want to share regarding trust? Anyone else? Soundar Raja, I see you have unmuted.
The good trust built by the good communication.
Yes. So excellent. So that is another thing that we need to express, that we have understood, that we are listening, we are aligned with them through good communications. And that is also an important part of building trust. But where do you see trust being expressed very, very explicitly? Can you think of any other? When we say want to do a surgery on a patient, how is trust expressed? We take this informed consent, right? So this informed consent, if you read the document, it writes about anything that can happen, including you may lose the limb, you may lose this, you may die on table, and still the poor patient signs at the end of the whole thing, even after listening to the whole thing, because they trust that we will do what is in their best interest. Correct? So that is a very important document of trust. It's not so important, it's not such a legal document or any other. More important is that we need to remember that they are signing only because of their trust in our professional integrity. It's a document of trust. We need to remember that. Informed consent is not something where, we just put a thumb impression on that and just, be done with it. But it's such a valuable expression of their trust that we will act in their best interest. So I have put in a few points here. So truth telling, acceptance of value, diversity. Like, as I told you, each one may have their own differences in value. So we may believe in something, they may believe in something, but as professionals, we come to a zero. We are always open and listening to them and thinking from their value, what is more important to them. So if the particular person does not want to be sedated when they are given painkillers which can cause removal of their conscious levels, because, so for example, I don't know whether you all have Jains in Sri Lanka. In India, we have a lot of Jains, and for them, and even Buddhists, for them, the most important thing is that they should be conscious when they move from this living world to the dying world. So they just don't accept the fact that, they may lose their, they don't want sedation during end of life. So acceptance of value, diversity. Here we cannot say in palliative care, we were taught that, suffering should be alleviated. For them, suffering will be even more spiritually. So we may have to accept that value and go accordingly. Timely communication, very well shared by Dr. Soundar Raja, and in the best interest of the patient. Truth telling. So as Dr. Jayarasa said, unless we are trustworthy, even our history taking may get affected, and we'll learn more and more about the patient as they divulge more. Informed consent, I brought it up to you so that it's a response to the trust that they express. All right. So similarly, the other aspect, the respect for life. So we generally, as medical professionals, we have a duty to care and preserve life and the living experiences of our patients. So many of the things that we do in palliative care are so focused on this principle in ethics. That is the duty to care and preserve life and living experience, because we look at life much more than beating heart and oxygenation being maintained. That is not considered. We look at the whole person. So the living, if the person is having living experiences, we try to make it positive. So in palliative care, the whole person life and the whole person living experiences are important, and serious health related suffering need to be alleviated. So again, this SHS that is being coined recently by the Lancet Commission, the serious health related suffering, the treatment is through palliative care at the physical, emotional, social, spiritual levels, because suffering can happen at all levels. Here we don't mean just continuing the heartbeat and the ventilation of the patient. We don't mean that by preserving life. But in some, at some level in conventional medicine, it could be that. But in palliative care, we look beyond that. The next thing is respect for the person, where confidentiality, dignity, privacy come, and also contextual openness. Because one day patient may say that, this is what I don't, I do not want resuscitation. Many of us, as we are healthy, if we are asked that in case where, there is a situation where you are completely dependent on others and you are very unlikely to come out of a dependent role, and you will be having multi-organ disease, would you like to be resuscitated in that context? In this, when we are very healthy, we might say that, of course, I don't want, and you will say, I'll be more for, do not resuscitate me. But then actually, when we are going through an illness, our hopes may be hanging on to different things. And we may shift and we may say that, no, I want to be resuscitated because this is pending. That needs to be done. I want to take 1% chance. So the vulnerability of the person changes, and they may shift in their, plans. And we should be open to that. We should be comfortable with the inconsistencies in views, and we need to make a consensual understanding which keeps moving with, as the patient's values change, because something which was completely unimportant to them may become suddenly very important. So trust, respect for life, and respect for the person, all of them are basic principles. Now there is something called as duty-based ethics, and that is what we generally look at when we do practice medicine. And the 4 cardinal principles, any guesses you all want to say? What are the 4 cardinal principles? Okay, I'll just go ahead. So they are non-maleficence, that is firstly do no harm. Beneficence is do good, whatever you're trying to do, the decisions. It should be of use to the patient, and it should be a fair allocation of resources, and it should be as per the patient preference. Patient should, want it or wish it. It should not be imposed against the patient's wishes. So these all look straightforward, and you have no, confusion in saying that, of course, these are good principles to have. We should not be harming, we should be doing good, and we should not go against patient preferences. But why we are having today's discussion is because there are usually dilemmas, because we may not be able to bring in all these aspects sometimes in clinical situations. So when there is a choice between good, what is the right thing to do, and what is the wrong thing to do, there is no confusion. It's very easy for today's discussion will be about some of these ethical dilemmas. So I'll be my leg is so painful, doctor. Please don't wait for all these, comorbidities to recover. Please amputate it right away. That is the request of. Yes, please. Hello, Dr. Jayarasa, you're saying something?
Yeah, no, sorry.
Okay. So one patient is requesting for amputation, and the other patient, please don't amputate my leg for this tumor. Please wait for it to recover. I need this leg. I am a fisherman, or whatever the reason is. So both these are reflective of which principle? What are the patients saying? We talked about non-maleficence, beneficence, justice, and autonomy. So when a patient says this, what are they expressing?
Patient's preference.
That is correct. That is autonomy. So that is called autonomy. Patient is expressing their choice. Now, the important thing when we look at autonomy is that, is it an informed autonomy? That is the part that we can help with. Because when they make a choice, are they really aware of the consequences of doing it, not doing it, or doing it differently? Do they know the options and all the risks, benefits of each option? So this is our role, So we need to make sure that whenever a patient expresses a choice, first thing we need to determine is that, is it an informed choice? Okay, any question on this? All right. Okay, let's move ahead. We have plenty more examples. So healthcare decision making. So I'm going to come up with some of these Indian Council of Medical Research definitions. These were brought in quite recently, about 1.5 years ago, because there was a lot of confusion regarding these. So they have defined several aspects of, medical ethics related phrases. So healthcare decision making capacity is the capacity of a patient to make an independent, informed decision. So our job, whenever a patient says a preference, is to make sure that they have been informed adequately. Now, shared decision making is a dynamic process for decisions. And here the patient and the healthcare team talks together. If the patient is not in having the capacity, then the patient surrogate. Surrogate means a person whom, say, I am the patient. If I've allocated my son will take the decision, then my son is the surrogate. Okay, so we need to make sure that it's an informed autonomy. So that is why the consent forms are, volumes and volumes, but very often they are not explained adequately. So when do we make sure that the patient has really taken an informed decision? So when we say the person has a capacity, there are a few things we need to understand. One is that they fully comprehend what has been discussed with them. Secondly, they are able to retain it in their mind. Then they are able to analyze that information, maybe, ask for clarifications. They can come back to you. We are open to having them clarify a few points. And then after their doubts are cleared, they are able to take a decision. So all these 4 components together make the capacity. Okay. So we need to make sure that we give them the opportunity to complete their capacity building. Then they are informed and then they can be autonomous. All right. So another concern I'm just bringing up. So here the person is saying that I understand I have a leaking intestine and that I may die, but I do not want surgery. Here, so what are the few points that would you like to say something more about this in this particular scene? Ethical dilemmas that you see, ethical concerns? Because see, our topic today can only be covered when you all contribute to some of these thoughts.
The patient might not know the consequence of leaking intestine.
Yeah, although he says that I may die, here he says that he may not know, that he may not know even the surgery aspect. Some of them have this idea that surgery is too much, and it is rather that I die rather than be in a undergoing surgery. So they may have misconceptions about surgery, and so we need to ensure that they are adequately informed, and this is really an autonomous decision. Correct. Anything else that comes up? Is there what about beneficence, non-maleficence? Would you like to discuss that in this patient? For example, this is a, say that it's very rare nowadays, but duodenal ulcer perforation. There is no chronic disease, nothing. It's a, acute disease which can be completely taken care of. So the beneficence is very high. And even in a general surgeon's, good competent surgeon, the surgery is usually reasonably safe depending on who's doing it. So it depends on the context, the setting, etc. Suppose it's a rural hospital without much help, and if not untrained person is doing this particular surgery can still be, it can threaten life. Whereas if it is done in a secondary setup where there is adequate facility and sterile environment and recovery, etc., it is a reasonably simple job. So beneficence and maleficence are not theoretical. We have to see the context of where this decision is being taken, what kind of setting it is, what kind of training, the capacity of the hospital as well as the professionals involved. And so he may be very justified in not undergoing surgery if it's a completely ill-maintained setting with untrained professionals. That may be a better option. But if it's a proper place, then so there's beneficence, non-maleficence, as well as autonomy. They all go together within the context of the decision making. Okay, so that is what I mean to say. So when we say non-maleficence, will this treatment potentially help? That means burden versus benefit ratio. We cannot just say in our setting. We need to look at where this patient is coming from. So is this treatment accessible? So we know that duodenal ulcer surgery is a simple treatment as far as even general surgeons are concerned. But again, it depends on the context. Is this possible in that particular setting, and patient's preferences? Does the patient genuinely not want it? Is it because of some misconception? Is it that he's having, you have heard of farmers wanting, there are people who may want to end their life. So is there some mental, depression? Is there some other psychological factors involved? Do we need to involve a little more with this patient so that the patient changes the mind? Sometimes they take it as a medical, opportunity. Okay, let it be done with it. Anyway, I wanted to end my life. So we need to look into these influences also when we align with these. So you can see that in none of these examples I'm giving you, this is the right way to go. It is the right way to think that we have to understand in ethics. Now, so this is a consent will be taken after the person can comprehend, retain, analyze, clarify, and then decide. I told you the capacity of the person needs to be made for them to be adequately autonomous. And we need to check and address the other influencers. Is there any depression? Is there any other misconception, some beliefs? All those we need to handle. Now, the next question is, don't tell my mother about her cancer diagnosis. This is something very commonly that relatives come to us to say. So how do you all handle this usually? Do you want to take some shots at how will you handle this ethical concern? Because as medical professionals, our job is to be open and trustworthy to our patients, and the relative is saying that please don't tell her about the diagnosis. It's very common in India. I don't know how, I'm sure it is quite common in Sri Lanka too. So how do you think we need to navigate our way in this ethical dilemma?
First, we can try the children that he has a right to know the information.
Yeah, so you're talking about the communication aspect of it. Before we start that, how do we approach it in our head before we start talking? Here you're trying to convince the, the son or the daughter. Before that, how do we understand the situation? Because in ethics, our action is always following the, the analysis in our head of what is the ethical situation. So Dr. Paul, what is the beneficence in this? What is the beneficence question in this particular situation?
Feel whether by telling that we will have to assess for ourselves whether the patient is very at that stage, whether she can receive that information, whether it will be beneficial to her or she will be going to deep depression and
yeah. So what you're saying is we need to understand whether this particular person, the mother, would it be beneficial for this mother to know the information, whether she can handle it, or is it right that according to the son or daughter that she just will not handle it? That we need to know whether it is beneficial or not, correct? So the beneficence depends on the background personality and the way she has lived her rest of the life. So that would be one of the important things that we will try to establish. So this will again be done through conversation with the people, with the family, because we don't know. So we can ask about examples, like, earlier when there were important decisions to be taken, was she the type of person who, involved in it, or she let others make the decision? So we can ask those questions to understand what kind of person she is. Now, again, non-maleficence is hinged on the same topic. Is she so nervous and so weak in accepting difficult situations that she, as the son or daughter says, will she collapse? Will she, lose all hope? And, so that also is the same conversation. We will get to know how she has dealt with her earlier life decisions. So this is done in conversation. So we understand that first we need to establish the personality. So it is not like always right that we need to tell the diagnosis to the patient. And it is not that, we should never tell the diagnosis to the patient. We need to assess the situation individually. So when you generally take a survey, most people, they prefer to know. There are always, even in my classes, when there are doctors sitting as audience, there are some doctors who say that, no, I rather not know. I'll trust my family, and I don't want to know that I have a life-threatening illness. I would rather not know. So there are people like that. So we need to respect that. So we look at it through the same questions. That is, would not conveying this information potentially help or harm the situation? So we are looking at the same question of, don't tell my mother. So we are looking at it whether there's any benefit in not telling. So that is by understanding the personality. And then suppose we are going to do the handling of collusion, if at all, as Dr. Paul was, suggesting. So is the resource available to handle this communication in place? There is staff, time, support, background information. There are, we need to be prepared. And what maybe the patient wants. So all these are interrelated. So every situation, if we look at it from different perspectives, we will be able to come to some approach. And then the approach keeps changing based on our conversation with the patient and family. I hope this kind of, discussing this topic may be helpful. So I hope that you can look at it from your perspective in this particular question. It's okay that I can't swallow any food, but surely I don't want a feeding tube. Please, doctor, don't put a feeding tube. So again, can someone, Dr. Sutesh Pavan, would you like to say what are the autonomy questions in this? What are the beneficence, non-maleficence, and justice?
In the non-maleficence is patient is don't like to put the feeding tube.
Okay, so she has expressed her autonomy.
Autonomy,
Yes.
yes.
Yes. So we need to make sure when someone expresses autonomy, what do we need to make sure?
Whether it's an informed
Informed. It should be
Informed, yes.
informed. So we need to make sure that she has received all the information of doing it, of not doing it, the risks and benefits as well of doing and not doing it, and what are the other options. So all these are included in her capacity building for informed autonomy. Okay, beneficence. What is the question in hand today for this topic? What are we dealing with? Putting in a feeding tube, right?
Feeding tube, yes.
Yeah. So what is the beneficence?
Putting the feeding tube is the beneficence.
Yeah. So the nutrition is the beneficence.
The nutrition,
yeah?
yes.
We are able to provide nutrition. Now, are we sure that, it is not going to cause any harm? Because this patient may be having esophageal or a pharyngeal cancer. That is the reason she's not able to swallow. That is the reason maybe that we are putting the feeding tube. And, if it is a PEG tube or some other way, there are, depending on the biological prospects, we need to make sure that what is the chance of this causing harm? Because sometimes the feeding tube in such a patient, it can just go into mediastinum. Yes. It can cause mediastinitis. So can we say that it is completely a risk-free procedure? No. So we need to, and also in one patient, it may be relatively very less risky because their anatomy is fine. In another patient, the same procedure may be highly risky. So the beneficence and non-maleficence ratio we need to establish for that individual, correct? So yes. Autonomy needs to be double checked. Beneficence and non-maleficence ratio needs to be double checked. And then we need to go ahead. Okay. So that is the plan here. And here, very often, generally as doctors, we tend not to look into the emotionality. So even if the person has an easy insertion of feeding tube from our professional perspective, and the patient is just not ready for it, do you think we can pass a feeding tube? Even if the risks are very low? So ethics says that we need to value the other person's values. As our value is to maximize life, maximize quality of life. But their value is what is their life stand, something they have not accepted their whole of life. I don't want to live by artificial means. If that is their belief, we need to respect that. So despite all the information, if the patient still insists, I do not want, we cannot force it in. It is considered as medical battery. It is it's a criminal legality issue. And also here we can support the decision. If we truly believe that this is going to help the patient, we can, show other patients with feeding tube, so that this lady or the, man, they will get their fear out a little bit. They can discuss with another patient. So that is, trying to help the person make a decision. That is weak paternalism. We are trying to say that if I were in this situation, I would have probably done this way. So that because all the knowledge and experience that we have, the way to convey it to a patient who has experienced it for the first time, or the family who is experiencing it for the first time, is by saying, suppose I was in your place, I would have probably done this. Because when we are saying that, suppose I was in this place, we are bringing in all our experience and medical knowledge into play. And so the patient gets an idea that, oh, this may be possible. So that is called weak paternalism. So strong paternalism is, I'm telling you, this is what you need to do. We are just telling them what to do, where they are not having much choice. Weak paternalism is giving them a picture. Complete autonomy as practiced in Western societies, where all the menu is put in front of the patients. This is an option, that is an option, these are the risks, these are the benefits, now you choose. So that is also extremely confusing to our population. They would like some advice as to how to proceed. So in India, we find weak paternalism is often required, because at the end of the whole conversation, the patient asks, tell me, doctor, what would you suggest, or what would you advise? So then we have to put ourselves in their shoes and then give a sort of a recommendation. So that is one more thing that we need to remember. And another thing here in India, and most probably in Sri Lanka also, there is a collective autonomy. In Western societies, it is individual autonomy. Each person chooses what is important to them and they decide. Whereas in India and in other Asian countries, very often the decision is together. Everyone in the family also gets involved in the decision making, and it is no longer a individual's decision. Like, my mother would prefer that I go ahead with some treatment, or, for the sake of my family. The person is always influenced by the family, or the family will together come and decide. So that is the culture. So that is also, we need to remember that it is very often not individual autonomy, it is collective autonomy. So another question from, as a doctor, I have 2 lakhs in my poor patients fund, and then I see a lady who can feed if I place a esophageal stent, which costs 75,000 rupees. Okay, should I go ahead or not? So this is a question of what we called, about resource, justifying the resource that is utilized. So if I spend 75,000 from my 2 lakhs fund, it is a big chunk of the poor patient's fund. So would you go ahead and use it for one patient? This is again no right and wrong answer. We could say that with that money, I can help bring pain relief to thousands of patients. Or you might say that, if you have a board, you may discuss it in the board, or you may find an alternative way of raising the 75,000, like a Facebook post, or, you must have seen social media asking for donations, etc. So there are various ways of handling it. But ultimately, here the question is that of distributive justice, whether it is our poor patient's fund or if it is the patient's own savings. Suppose the patient is going to sell the house they live in, because many patients, at least in India, less than 15% have insurance. So if they're going to give their life's earning, sell their house or pledge their house and come for a treatment, they're hoping that they'll go back home walking. So financial toxicity, catastrophic expenditure is a huge issue in India. Millions of people go below poverty line. So distributive justice is about whether it is appropriate to spend that kind of money for a particular treatment when the outcome is not very clear, or should we just keep that money for the children's education or for the food of that family, rather than squander it all in one person's expense. So that is squandering. Again, I've used a word like that, but we need to look at resources. Resources need not be just money. Suppose you have, say, 3 ventilators, and you get a very young patient with a vehicular accident, and you get another patient with multiple, multi-system failure with a chronic disease and metastasized cancer, and two ventilators are already occupied. So this third ventilator, whom will you give? To a young person who has got vehicular accident trauma, or to the person with multi-system failure and a terminally ill cancer? So these are the questions of distributive justice. So can you share some thoughts on this? Because that will be an important principle that we need to cover.
You can also type your answers in the chat. We'll read them out for you.
Okay, that will be quicker. So if there are any chat answers, you just share it with me, okay? So these are the kind of dilemmas you understand. So it is not easy to have all these 4 principles managed in any situation. There are always, one pull will pull the, like suppose you go for the patient autonomy, the beneficence may suffer. When you go for beneficence, something, justice may suffer. So we may have to find a realistic path to have all these put together. Now, yeah, so this I'm again talking about in this particular scenario. We need to have a consensual understanding through communications. So now this is another question.
Someone says, sorry, someone says young patient in the chat.
Someone says?
Young patient. Young patient. So to put young patient in ventilator.
Okay, yeah, young patient, okay. So this is another, yeah, so this is another scenario where this patient has, he's 63-year-old, he's got COPD, diabetes, he has already been admitted in ICU for 4 times in the last year. He's already on ambulatory home oxygen. He has breathlessness with, a worsening blood gases. X-ray shows emphysema. There is cor pulmonale, there is polycythemia, which indicates that it's a long-standing illness. And she's not responding to usual management of steroids, bronchodilators, antibiotics. Would intubation, ventilation be appropriate care in such a patient? All those who think it is appropriate, raise your hands. It's okay, we are just learning.
Someone says no, ma'am. Dr. Sandeepan says no.
Okay, so Sandeepan, congratulations, because you responded. Okay, everyone just feel free. Okay, we are here to just learn. So yeah, so thank you for responding. So here again, we can see that we need to understand futility and utility of any intervention when we are discussing. So I've given you some background. So if you just look at breathless patient with disturbed blood gases, the immediate response is to put the patient on ventilator to improve those parameters, and that is called the effect. The effect of a particular intervention. Beneficence is something that the patient is able to perceive. So when we look at beneficence, it's different. And so improving of the saturation will be an effect. Whereas a person getting discharged and walking home, or patient, able to sit up and eat food, is a beneficence. So when we are discussing with the family, we need to look at beneficence in such a patient. Here, he is a chronically ill patient, already a very poor functionality. So correct, absolutely correct answer. That is how we would decide, because will this patient be helped by this treatment? Is this treatment accessible in that particular situation? And what has the patient lived by? Some of them may have already expressed that they do not wish to be having prolonged dying, because this is not prolonging their life, it is prolonging their death. Another way of looking at it is by the 4-quadrant approach of decision making. So benefits versus burden is looked at. So what is the best possible outcome, the worst outcome, and the likely, that is somewhere in between. So what is the likely scene if you don't give it, or what is the likely scene if you give it, and what are the other options, what has been. So the other question is, what is the competencies? So is it as per the hospital policies? There are some end of life care policies in hospitals. There may be advanced care directives in that land. So we may look at the patient's advanced care directive. Then how about the critical care setup for such a patient? Is it going to help the patient, or the patient is going into another, horrible experience of ICU? And do we have the necessary resources to rehab this particular patient? So all these questions come into play. And then there is autonomy. Does the patient have the capacity, or is there a surrogate decision maker? And what is the impact of on the quality of life. Is it the risk and burden acceptable to the patient? Does it disturb what is most important? And would the quality of life be worth it? So these 4-quadrant approach is another way of looking at very complex clinical situations: benefits versus burden, patient's autonomy, the context and competencies, and impact on quality of life. So we come to the point of proportionate care. Proportionality is the fundamental ethical consideration in patients, where the background of the patient is not just the presenting features that we look, but the entire background, the functionality, the whole person, the attitudes, what is meant by quality of life to that patient, etc. So the same situation I'm giving you, but differently. This is a 76-year-old patient, is ambulatory. He's also COPD and smoker, but he has had one admission over the last 6 months. He is come with breathlessness, cough, and disturbed attach.
I'm sorry, there is a lag. There is a lag in your voice. Hello, Nandini ma'am.
And
Nandini ma'am. Nandini ma'am, sorry to interrupt. There is a lag. There is a lag in your voice. Sorry.
Whether you
Completely lag in your voice. We missed everything. Sorry.
Oh, I see. So any thoughts on what should be done with the second patient who's showing pneumonic patch, a leukocytosis, and coming with the similar symptoms as our 63-year-old? This is a 76-year-old ambulatory. Would you intubate and ventilate this person? Because is there to be treated, is responding to bronchodilators, patient quality of life, he was ambulatory, and etc. So there are, so if we go just by the age, breathlessness, and this thing, we may make that's why I made this patient older than the other patient, because it should not be even ageism. Just because somebody is older, we don't give a preference of interventions, etc. So that is the reason we need to look at individual patients' beneficence and not the effect, and accordingly make ethical decisions. Okay. So going ahead, I think I have a few more scenarios. So here, as we move from healthy to unhealthy, so what may be appropriate towards the very late stages of a chronic disease may not be as appropriate here, because when a person has chances of recovery, we need to give that chance. So just we cannot say that any patient with COPD coming with breathlessness. So we need to look at the background and decide. At the same time, we should not be doing artificial invasive interventions in patients who have who are going to increase their symptoms, who are going to suffer more, whose burden is only going to increase, and their life is not any better, but the death gets prolonged. So that is an important consideration. So futile care is care that fails to achieve the minimum benefit that we would want through that intervention. This is an important principle too. Sometimes, we get so, like we talk about conventional medicine as organ-based treatment. They don't look at the whole person, etc. But nowadays, sometimes palliative care organizations, it becomes organization-based. So then it's like, we are palliative care, so we will not resuscitate. We are palliative care, so we will not put the person on ventilator. It's not correct, because now the profile of palliative care patients have changed. They are no longer always, towards the end of life. We are getting patients at the earlier stages. Patients may be on curative treatment. So we should not go by our organization. We should not have anything pre-decided. So in conventional medicine, any patient who comes with a cardiac arrest goes for CPR and maybe put on ventilator. And in our in palliative care, we say we are palliative care, so we will not resuscitate. Both are wrong, because both are rigid. We need to individualize, and so we should not get carried away. So that's why this term I liked it. Organ-based, we talk about others. So we should not be organization-based. So our decision should also be making sense and contextual to the actual patient situation. So we are actually on, we have come to a particular time. I didn't go to the Indian law because, it doesn't go well with, I don't know the Sri Lankan law at all regarding, is there advanced care directive in your country? Do patients have a system of writing what they wish to do in case and some event happens and certain scenarios like so then that's something what we did before. We have something in India now. I don't want to discuss that because it's irrelevant. But before that happened, and even now, what we do is we don't rely so much on the legalities. We rely on communications. So as and when it is possible, we communicate. We try to make them understand their insights on their disease, and try to understand what is their most important value. How would they like to approach? So it can be done, as a documented communication, so that we know what they want. When it comes to advanced care directive, it becomes very formal. And in India, at least, it is no longer, it's not in a stage where it is practical to use. Because, when suppose I am sick, and so sick that, actually there is a question of whether I should be put on ICU or not. Even if I've written an advanced care directive, my son will have to run and convince the doctor that, there is an advanced care directive. Then the hospital has to call a group of specialists, including neurologists, cardiologists. Then they have to all come and see me together. I'm at the threshold of ICU. Okay, my trolley has been pushed up to the ICU. And then my son says, no, she has got an advanced care directive. So then the doctor has to call for a committee. And then this committee has to come and see me together. And then they have to say, it makes sense, may not be. Or if they say no, then my son has nothing to say. They will push me into the ICU. Now, suppose this committee, hospital committee, says that, yes, she has a point and we need not send her to the ICU. You know what the hospital has to do as per Indian law? They have to inform the district collector. The district collector has to call in a panel of, again, completely different set of specialists, including the district medical officer. And they all have to come and see me together in this hospital where I'm waiting at the threshold, gasping, and they're deciding whether they want to intubate or not. And they have to come and see and decide whether it's the right decision not to put me in the ICU and ventilator. So you see, and the Supreme Court has given them 3 months time to make this entire act happen. So you can imagine how impractical it is. So we still rely, what we call it as, communications in advanced stages of disease. So it's a simple document where we have written the scenario, the patient, and this is not done when the patient is at the threshold of ICU. This is to be done when we see the patient is deteriorating. So then we discuss with the family that, see, this time the patient has come out reasonably okay, but next time it may not happen. So can you think of, what are the alternatives? Can you discuss with the family? So there is rationality possible, because at the threshold, if you ask the relatives, what should be done, DNR or not, CPR or not, should we push him? It's all emotional decision. They will say, do something. Because what they're trying to say when they say do something is, don't let this patient suffer like this and gasp. They don't understand what happens inside the ICU. They don't know muscle relaxants are there. They don't know that, the tube will be shoved into the throat, that it is going to disturb. They're going to be sedated. They don't know anything. They feel the patient is going to be calm. So what they're asking you is, make him or make her comfortable. And it is difficult to explain this whole thing when it is actually needs to be taken there and then. So the most important aspect of end of life care thing is to start discussions early and have things documented. And it need not be, as I told you, the views may change, and we need to be open, and we need to stay connected with the patient regarding all this. There are several points that, I would have still like to talk about, but it is 8 o'clock. So I will.
No problem. Please continue. You can take another 10-15 minutes. No issues at all. Please go ahead.
Are the participants okay with it?
Yeah. Is that okay with all of you? Shall we continue for another 15 minutes? I checked with the faculty.
Yes.
Madam has agreed.
Yes,
Thank you.
Yes.
Thank you.
All right. So we were discussing about that we should not be, just because we are palliative care, it's always conservative. Sometimes because our profile of patients have changed. All right. So now, yeah. So there is, being a palliative care does not mean no CPR. And so avoid presumptive blanket yes or no to resuscitation policies. So this was, published in Palliative Medicine, and heterogeneous patient populations are increasing in the palliative care ward. So, and another thing is not to offer CPR as a choice to the family. We decide whether the CPR is going to be beneficial. And then we say, then only we offer. If it is not beneficial, I don't know whether it is required to be offered at all, because we don't want to do something which is not in the best interest of patients. Now, the other patient, here the patient is in an advanced stages of cancer and in the terminal phase and gasping. And she's crying with pain, okay? And she has had difficulty with swallowing and has been unable to take anything orally, including her tablet morphine, since 3 days. Her mean arterial pressure is 60 millimeters of mercury. So you see a patient who is poorly hydrated, in excruciating pain, and her BP is on the lower side. Would intravenous morphine, which is the painkiller that is available with you, appropriate for relieving her pain? So here, because of shortage of time, I'm not opening it to discussion. So here the principle, ethical principle that comes into bearing is the doctrine of double effect. So you see, she has a low BP. Intravenous morphine, we know, will cause venodilatation, and it will, further bring the BP down. So it may cause an event. At the same time, is it ethical to leave this person crying in pain? Patient has, we know the dose of morphine that needs to be given also, because she was on a regular morphine. So there is a double thing. On one end, it may hasten death. At the other end, it will alleviate suffering. So the doctrine of double effect states that when their intention is to have the beneficial and alleviation of pain, the possible side effect of probable causing of death is acceptable. That is the doctrine of double effect. Okay, so intention here is more important, not the act. Although we know that this is one of the side effects that is possible. Now, another way of looking at it is, okay, if morphine has this side effect, are there other ways of relieving this pain? Can I access somehow parenteral fentanyl, because that is more cardiostable? Or is there a way of quickly, improving the hydration and then giving it? So there are various ways of looking at it, but I'm just saying, when we give something which has a possible harm and we still give it, because see, for example, sometimes we have to give consent where, we accept the death on table, but we believe that this particular surgery may save the person. That is again a doctrine of double effects, although it has never been discussed that way. But in palliative care, this has come up because several times we need to make decisions in the best interest of patient, which may have deleterious side effects. So principle that distinguishes the effects that are intended from those that are unintended. This is the most important part, the intention behind the actual action. And both are foreseeable. Now the next one. Of course, this is the explanation of that. So fundamental ethical responsibilities to ease suffering, particularly when intolerable and in those close to death. So that is the basis of accepting the doctrine of double effects and still giving pain relief, even though it may cause further hypotension. Now, this is, all of you know, was our Prime Minister, and he was 93-year-old with ischemic heart disease, stroke, dementia, and he had kidney failure. He was kept on dialysis from 11th of June 2018 to 16th of October, and even in the last few days, he received the extracorporeal membrane oxygenation support. Okay, so these are the kind of things that happen to extremely important people who have, no choice. He was demented, he had no choice in the matter. And what happens is everyone around them. So the more famous or more well-to-do or, more connected you are, there are people who will make sure that you are, all the things that are available in the land is given. So there are patients who come with, this is particular article was published in the New England Journal, where the patient came with this tattoo on his chest to not resuscitate. This was seen in the 2017 publications, if you look up in New England Journal of Medicine. And finally, after discussing with the ethics committee, patient's wish was honored because he had taken so much of trouble to ensure that the medical decision is, seen as well as offered. So they decided to go for it and they did not resuscitate him, but after a discussion. So I'll just skip through these because I have just given you already a brief about, the discussions there. So as I told you, it's quite, as of now, it's a very not at all useful law, which is happening in India. A lot of action needs to be done. I made all this because I didn't know it was exclusively Sri Lankan audience. So, okay. We come to now few controversial topics, that is sedation. So sedation, palliative sedation is intentional administration of sedative drugs in dosages and combinations required to reduce consciousness of a terminally ill patient that is necessary to relieve the refractory symptoms. Okay, so this is the definition I've taken from Dr. Robert Wycross's elaboration on this topic. This includes continuous, intermittent sedation, light and deep sedation, everything. Okay, so you must remember that the sedation is intentional. And what is the intention? It is to relieve refractory symptoms. And it may be given in dosages or in combinations. And the aim is because when the patient is conscious, the symptoms are intractable. They are refractory. Patient is suffering. So the only way to reduce the symptom is if with consciousness, if it's not going away with all the tricks of the trade, is to reduce the conscious level. So that is the only point when it is justified. So it can be in some countries, it is considered normal and ethical responsibility to ease suffering. And in some countries, it is always the exceptional last resort measure. So the examples, so it is an intended reduction of consciousness, as I told. So it may be initiated as, from the patient, and decision is done by the doctor of how to do it. And role of the doctor is to evaluate the need and in congruence with the guidelines of the land. So it's normal in some places and it is radical in some other places. So we need to understand that in at least, I don't know what the rules in Sri Lanka, but in India, it is not used for existential suffering, etc., but it is very much used for physical symptoms which are intractable after all the possible combinations of medicines, references, non-pharmacological, everything is tried. If it is still not possible, palliative sedation is done in India and it is accepted. So the ethical controversy is because it ends the biographical life of the person, because the patient is no longer able to interact with the family. And so it is almost like after that, they are no longer in communication, because ultimately life is conversations and experiences. So for the family, it is like losing the patient before the patient actually dies. So that is the reason for this ethical overbearing. But we need to remember that in sedation, when we give palliative sedation, we go proportionately. We give the sedation as per the requirement. So we titrate the dose. And as soon as we get the desired effects, and we may lighten it to make sure that the minimum dose is used. The intention is not that patient should die, but as a side effect, as the sedation proceeds, because this is given towards the end of life, patient will ultimately die. But that doesn't mean that sedation has caused it, because the intention was to alleviate the symptoms. Okay, and also we do monitoring to ensure that the minimum dose is given. Whereas when it is given for euthanasia, the intention of the drugs is to end the life. And so that is the main difference, the intention. In any ethical controversy, we need to look at the intention of why it was given. So another point of question which MNJ has asked me to look upon is artificial nutrition and hydration at the end of life. So again, withholding and withdrawing is, it's generally food and drinks are considered expressions of care and affection. So there is a lot of emotions attached to it. The family feels terrible to eat themselves when the patient is not able to take food and drink. So that is an important acknowledgement that we need to make when we discuss things with the family. And they feel that it is absolutely a curse to die while suffering hunger. They feel that they have starved the patient to death. Okay, so these are the different things that make the family so miserable when they are not able to feed the patient till the last day. So it's a symbolic comfort. So the question is, when is it correct, when it is not correct? So in India, there are no rules against, like, it is not like if you go to a hospice, there are no food and drink given. There is no such rule. So we go again case by case basis, and we see the beneficence and maleficence of giving it or not giving it. So sometimes the patient may, when we give, continue to give enteral, if the patient is accepting it, it is okay. But suppose, do you want to pass a tube to feed the person just because, you want that symbolic comfort to the family? It's all very, very individualized decisions. Is it going to harm the patient? Is it going to benefit the person? Is it the right thing to do, etc., etc.? So enteral, if at all we choose it, it is given as enteral nutrition and enteral hydration. And parenteral is absolutely, not practiced in the end of life situation. And even the enteral
Hi,
nutrition.
Dr. Velath.
Yeah.
It's Jonathan Pierce here from Vancouver. I just wanted to mention, we actually have a session on artificial nutrition and hydration
see.
right
Because-
after this.
All
So
right.
I think it would be good if you could just maybe wrap up
skip it.
quickly. And we're going to be going into that as soon as you're finished. So
Sure. Yeah. So then Vinila has specifically mentioned in her invitation that I'm supposed to speak. In fact, I had not put it into the list and I added it. So I'm glad that you clarified it. So that will be discussed in detail, but I'm sure that there will be more learning about it. And I think I just don't need to talk much more about. Maybe this is a bit, because in India, there is this custom of Santara, where, the Buddhists, they choose to end their life without eating. And now the Supreme Court has sort of allowed that. There is a stay. Initially, it was considered as illegal for in between when there was a public interest litigation. And now the Supreme Court has stayed that. So now they are allowed to, as of now, the Supreme Court justifies Santara rituals by Jains. So this also comes under. So coming back to this example of Ms. Sri Atal Bihari Vajpayee, who was given a lot of interventions, and we know, he was a poet. I don't know how many of you can read this in Hindi, but it's a beautiful poet about his philosophy in life. And such a person, imagine, he was put for months together on ventilation, and then, extracorporeal membrane oxygenation, etc. So the best interest of the patient is important to consider, and think about how the person would have wanted this to happen, and then choose the interventions. Use the 4-quadrant principles. So alternative pathways for our late Prime Minister could have been that, we could decide against the hemodialysis using the Renal Association criteria. That already this criteria had existed and he was fulfilling it. He was 93 years of age. He was demented. He was unstable medically. So many criteria were already met. So if he had truly gone as per the guidelines, he would not have been put on even hemodialysis. Or we could have had open and honest interactions early, documented some of his wishes, and then given a conservative care instead of hemodialysis. And here is another picture of Bush, where he chose, comfort care, and this was his last words, and he passed away uneventfully. And even his wife, she chose to not have any artificial intervention. So they all had home-based death, and she decided not to seek additional medical statements. So it has nothing to do with resources. It has nothing to do with available or accessible facility. It is patient's autonomy when it is informed, and when we are empowering it, that is the best ethical decision towards end of life. And this is a Sanskrit verse, and I'm sure that because you all are not familiar with it, I will not come. This was very useful for an Indian audience because they would know that shloka. Thank you so much. And I hope I have brought in some of the concepts into your mindset, and there is a lot more of discussion, and you all have so many more opportunities to look into these topics.
Any questions from the participants? You can always ask, type your questions in the chat box. Ma'am, are you going to stay back, or you have something else to do? So that Nandini, ma'am, you're
Of course, yeah. We
will
can
stay back. So you can always.
Are there questions now? Oh, there was a session on palliative sedation as well. Oh,
Yes,
okay.
ma'am.
Okay. Vanilla, in your invitation, or when in your Zoom invitation, the nutrition hydration part was added extra. So I thought it was part of mine. I'm so sorry.
Okay.
Yeah.
Sorry. Yeah. So I just put 2 sessions, one after the other, because it's for today.
Okay.
If there are no questions from the participants.
Okay, I assumed it was all my topic.
No. Sorry. Maybe I didn't clarify. Sorry. Thank you. If there are no questions, we'll move on to the next session. The faculty is already here. Is that all right, Nandini ma'am? But sure, definitely.
Absolutely. Go ahead.
We'll come back to
Thank
you,
you.
and there are more. I think within
Please
a month's
share
time.
Please share my email ID so they can just send the questions to me. Okay.
Sure. And we are anyway. Is it all right if you share your presentation into bit of format with the participants as well?
I've sent it to you, Vanilla. I've sent my
I
presentation.
got it. Thank you, ma'am. Thank you once again, and it was really nice
Bye.
having you with us this evening. Thank
All
you so
the
much.
best. Take
Bye.
care.
Bye. Jonathan sir, over to you. I know we are running out of time, but still, please, Jonathan sir, over to you.
Okay, yeah, thanks, Vanilla, and thanks so much, Dr. Vilath. That was just fantastic overview of ethics, and it's such an integral, important part of palliative care. And I think your summary of trying to balance all the factors is a very big thing that we face every day, with balancing suffering that we see patients in, and our own understanding and wishes for patients, and then trying to meet their own wishes themselves in the context of advanced disease. So it's a big, complicated part of the job, but can be very meaningful part of the work if we think through it all together. So I want to introduce Danielle Down. She's a doctor here in Canada, in British Columbia. She's a family doctor and a palliative care doctor. She works mainly in Nanaimo, which is just a ferry ride away from Vancouver here. But she also does some work in smaller, more remote, far off places in Canada. It's a big country, and she goes up north and goes to some smaller towns and does some rural medicine as well. So she's very experienced in a lot of different settings. She is also working with the Two Worlds Cancer Collaboration Team, and particularly with the Nepal education efforts that are happening there, but she was very keen to be involved with some of the work.
All right, so like Jonathan said, I'm going to be talking about nutrition and hydration at end of life. So I think that this presentation will complement Dr. Valeth's presentation very well. A lot of the conversation that Dr. Valeth had with you is very similar to what we'll cover today. So I'm going to try to get through a couple of things. I know we're a little bit short on time, but I think we'll be able to make it work. I'm going to discuss some general principles and then also a framework for how you might think about treatment preferences when you're thinking about nutrition or hydration in palliative care patients. I'm going to go into a little bit more detail on hydration and then nutrition or feeding, and then we'll end with a case just to wrap up all of the conversation, and then questions at the end. But like Dr. Valeth said, if there's any point where you want to clarify something or add a comment or ask a question, please unmute yourself and do so. Please use the chat box. I'm happy to be interrupted to clarify or answer questions. Feeding and hydration is a challenging topic. It's difficult for patients and families because feeding or food is often a symbol of caring. Foods can also have a very important cultural context or a religious context that maybe we aren't familiar with ourselves. There can be a lot of fear and misperceptions from the patient or the family around what is the natural dying process and what happens when patients are in the late stages of cancer or end organ disease. So these are things that we need to consider when we're seeing patients and their families, and they might be asking about nutrition or hydration. It can also be a difficult topic for us as care providers, physicians, nurses, and other allied professionals. We don't have much evidence on the topic, particularly in our palliative care population. A lot of the recommendations that we make are individualized, like Dr. Vallis spoke about. We don't have any solid rules that we have to follow. Everything will depend on the case, the person, their disease, their prognosis. So many factors have to be taken into account. A lot of what we recommend might be based on our own experience, what we've seen happen in previous similar situations, what our colleagues might have done, those sorts of things. And then because of how uncomfortable this can be for patients and families, it can also be really uncomfortable for us to bring up the topic or to talk about it, especially if we're trying to weigh those 4 quadrants of the medical ethics and we feel like we might be actually doing more harm than good, but the patient's autonomy is that they want to pursue this treatment. Those can be challenging conversations to have, especially when your viewpoints are clashing or against one another. So just a couple of principles here. Like I said, there's little evidence or controlled trials done in our palliative care population to support doing hydration or nutrition or not doing hydration or nutrition. I think we can understand that particularly when patients are close to death, intravenous therapy for either fluids or food could be an unnecessary intrusion. On the other hand, there might be opportunities or scenarios where we think that starting intravenous fluids or food could be appropriate. Maybe there's a correctable or reversible medical condition, or maybe in this scenario, it can help with comfort. Ultimately, like I said before, and this has been the theme throughout today's sessions, our decision-making and our management will depend on conversations with the patient, their families, and what their interests are. So that idea of autonomy, as well as what we feel is appropriate and what our recommendations are. So some arguments for hydration, depending on the case. We know that hydration might help relieve or reduce confusion, restlessness, or agitation. It could also help with thirst. Intravenous fluids may help improve our renal function of a patient. And we know that a lot of the medications that we use in a palliative care setting can be processed through the kidney. And so if fluids through the intravenous may help the kidney function, maybe there will be less potential side effects from our medications. And sometimes patients and families feel like this is the standard of care. So if they get admitted into your hospital and everyone else around them has an intravenous with fluids running and they don't, they might think that their care that they're receiving is different than someone else's who's next to them in the hospital. Here's some arguments why we might not want to consider hydration. You can see that this list, which is not including all of the arguments, is a lot longer than the reasons why we might start some intravenous fluids. So certain things that are probably most applicable in our palliative care population, the patients that are close to dying, is that intravenous fluids can be difficult. It's hard to find veins to insert an IV when patients are close to dying. They often fail, they're quite painful, and we might need to restart it. I think you've also probably seen cases where we continue or start intravenous fluids and it causes more harm than good. So in patients that are close to dying, we might see that the intravenous fluid actually causes more edema, more swelling in the legs and the sacrum, which can be more painful. It can also cause more respiratory concerns. It could increase respiratory congestion, leading to coughing, more mucus production, or increasing a patient's shortness of breath. So like was mentioned previously, we're going to need to weigh the risks and the benefits of these types of interventions based on the scenario that we have in front of us. So some of the reasons where I might consider to start intravenous for fluids related to our population would be some of these considerations. So for example, if a patient has a high serum calcium because of either their cancer or maybe due to cancer-related treatment, one of the first lines of how we manage these patients is to rehydrate them with fluids. Often, if the patient is admitted to hospital, this will be done through an intravenous. Similarly, with opioid-induced neurotoxicity. So this is a syndrome where the medications that we're giving patients for their symptoms, like for example, morphine, can break down in the body and actually cause more harm than good. You've also probably seen patients get intravenous fluids before surgery because they aren't eating or drinking, and we know that this has an impact on their organs. You've also probably seen patients post-surgery also have an IV until we're certain that they're able to eat and drink on their own. Of course, we probably don't see many surgeries happening in palliative care patients who are near end of life or who are close to dying, but these patients might have undergone surgery earlier in their disease process. Sometimes the patient and the family request hydration for different reasons. I've had a patient ask for intravenous therapy because of, so maybe they're unable to swallow because of their disease process, or maybe even if they are able to swallow fluids, they still feel thirsty. We may try an intravenous to treat the symptom of thirst. But you'll note here that we say a trial period, and I'll get into this in more detail later on. But really, anytime we're making interventions like this, we need to always reassess whether we're still doing good or if we're adding more harm to the patient. Another reason might be that the patient or the family wants to try to prolong life. What I mean here is a short period of time. Recently, I had an elderly woman come in with metastatic lung cancer. She had brain metastases and bone metastases and liver metastases. When she was brought into my palliative care unit, it looked like she probably only had a couple more days to live. She would open her eyes when you talked to her, but she wasn't really talking back to you when you asked her questions. She wasn't eating or drinking anything for the last couple of days. The family expressed to me that she had 2 grandchildren who were living out of the province, and it was going to take them a day or two to arrive to say goodbye. And it was really important for both the patient, the grandmother, and also the grandchildren to try to be able to say goodbye while she was still alive. So in this scenario, I opted to try to start some intravenous fluids for the short period of time while we waited for the family members from out of town to arrive to say goodbye. But again, this was a discussion that we had where I very, very clearly outlaid why we were doing it and for how long and what the potential risks were. At the end of the day, and I think Dr. Vallis spoke to this quite well, sometimes the patient or the family, whoever is making the decisions, have the autonomy or the decision-making capacity, and they insist on doing it. Even if you feel like the risks or the harms outweigh the good, we have to work together with our patients to support them and listen to their values and interests. In this scenario, maybe we're starting it even though we don't feel like it's appropriate, but again, it would be a trial period and something we're always reevaluating. We should not start hydration if the patient says no, or if there's an advanced directive or previous communication with the care team that this is not something that they would want. I think Dr. Vallis spoke to this well, where we may understand that there could be benefit from hydration, but if the patient acknowledges the risks and the potential consequences of not having an IV started, then we need to accept their decision-making, provided that they're capable of making it. Sometimes we as physicians and nurses feel helpless and that we need to do something. And maybe we've tried a lot of other things and we haven't yet tried an intravenous. I would caution you from starting it just because you feel you need to do something. There should be a clear reason why you're starting fluids or feeding as the physician or the care team. And like I spoke about earlier, Hydration can cause increased respiratory concerns like congestion or edema. If the patient is coming to you and they already have significant congestion or significant edema, or they're very fluid overloaded, I would caution against starting artificial hydration in this patient category. This is just an example of how I approach discussions with patients and families about artificial feeding, nutrition, hydration. So before I talk to the patient and family, if I'm not already familiar with the case, I want to review the case. I want to understand the patient's disease, where they're at in their disease journey, whether they're undergoing treatment for the disease, what treatments have been tried, what is their prognosis, and how close are they to dying? And then I also want to try to understand if there are any cultural or religious aspects that might influence their desire to have artificial hydration or nutrition. And then part of this is also identifying, are there any medical reasons why I should consider hydration or nutrition? So like the last slide that I talked about, maybe they're admitted to hospital with a high serum calcium that could be reversed with hydration. When I go to meet the patient and family, I want to ask them, what do they understand? Does the patient know the prognosis? Do they know of their disease? And I want to see if their understanding is similar to my understanding. I'm sure that you've come across scenarios where the patient thinks that they have many years to live, when in reality, based on your medical assessment, they may only have weeks. This difference of opinion can also influence and so this opportunity patient and or the family or decision makers, so that everyone is on the same page and level of understanding before making a decision around treatment. I think it's important to discuss what the patient's wishes are and values, and whether or not they have any preferences. And like Dr. Vallis said, these are emotional times for our patients. Anyone who is acutely dying can be scared, and their family can be scared. And food and fluids can bring a lot of comfort, so there's a lot of emotion tied to them. It's important that you acknowledge these emotions, but also share your recommendation and your potential concerns, especially if what you're recommending is different than what the patient or the family is hoping for. And with any decision, you need to establish a clear plan with a clear goal. So what are you starting? Is it through the intravenous or is it oral? What type of intervention is it? How long are you going to try it for? How often are you going to reassess? And what are reasons why we would stop or why we would continue? Having all of this reviewed up front with the patient and the family makes it easier as the day goes by to reassess and stop the treatment if it's not helpful. I'm curious where you work. I've been talking about giving hydration artificially through an intravenous, but there are some other ways of giving hydration. And I'm just curious at your medical centers, what other ways you can give fluids, or have you given fluids? If you would like, you could just unmute yourself, or you can put it in the chat.
You can put your question in the chat, also raise your
NG.
hand. Yeah.
Nasogastric.
Nasogastric, yes, yeah, through a tube, exactly. Anything else?
Any other comments? IV, someone says IV in the chat.
Great, yes. So I think when we think of artificial hydration, we often think of intravenous or IV. in Canada and in our palliative care population, like I mentioned before, intravenous can be challenging because it can be hard to find a vein, especially if the patient is close to dying, or if they've had a lot of chemotherapy, for example, which can be hard on the veins in the future. So often in Canada, at least, if we're trying to give someone fluids, we may opt to give them subcutaneously. So this is a route under the skin, which is less painful because we don't need to use a vein. So it's often easier. However, we can only give fluids at a much slower rate. So with intravenous, you can do 100, 125, you can turn it on completely wide open and give a large bolus of fluids very quickly. With subcutaneous, we have to use a lower rate, 25 or 50 cc's or milliliters an hour or less. And often I find that these sites don't last as long as an intravenous, so there's some trade-offs between these different routes. And one of the participants mentioned a nasogastric tube, NG tube, other tubes we can give feeding through as well. So basically with this, it's again coming back to assessing the case, the scenario, what are the resources available to you where you're currently treating the patient, and what might be appropriate for them. Moving on to nutrition and food, really our aim in a palliative care setting is to improve the quality of life. I think all of us could think of our very favorite food in the world and think of the taste and the texture and the flavor and how you might feel if you could never eat that type of food or any food again. Similarly to hydration, we want to ask, whose problem is it? Is it the patient or is it the family? I've met a lot of patients who they don't have an appetite because of their advanced cancer diagnosis, but the family is very, very concerned that they're not able to eat or drink. And then I've put us as the healthcare team at the end because sometimes we're the ones worrying about it, but the patient or the family isn't. I also like to ask, what is the issue? Is the patient not able to eat because they're nauseous and vomiting? Or are they not eating because they don't have an appetite and that's related to their disease? Maybe they're presenting with weakness or a loss of strength, and their belief is that the reason they have this is because they're not eating enough. Or maybe they just want to live longer and they feel like artificial nutrition will help them achieve that goal. We'd like to try to use foods that the patient likes. We have a rule on our palliative care unit in Canada, which is there is no rules. If the patient just wants to eat sweet treats or desserts, then they're just allowed to have that. There's no limitations or restrictions. They don't just have to eat healthy food. It's whatever they feel like at whatever time, whatever they would like. Sometimes we get asked about whether artificial nutrition makes sense if a patient is malnourished or has malnutrition. This can occur in 40 to 80% of cancer patients and does contribute as a major cause of morbidity and mortality. It may be related to the cancer itself or the disease. For example, if a patient has esophageal cancer and they cannot physically swallow because the mass is blocking the esophagus. It could be related to treatment for the cancer. For example, a chemotherapy regimen, which then causes bad mouth sores, which are painful and the patient can't swallow food. A big thing that we see in almost all of our palliative care patients would be cancer-associated cachexia syndrome. This is just a label to describe the physiologic changes that happen when a patient has advanced cancer or advanced organ disease. It results in the patient not feeling hungry or thirsty and therefore not wanting to eat or drink. And even if a patient with advanced cancer or advanced organ disease feels hungry or thirsty, no matter how much they eat or drink, they often continue to lose weight and decline in terms of their strength and weakness. When we think about artificial nutrition, and this could be parenteral through an IV or enteral through a feeding tube, the use of it in cancer patients has not been shown to improve mortality, meaning it doesn't prolong life as most patients or families would believe. And there's actually a 40% increase in the total complication rate. So we may actually be doing more harm than good if we choose to start this. There are some very rare cases where this may be indicated. So for example, if the patient is very malnourished and early on in their disease, so they have either a potentially curable cancer or a good chance of longer term benefit. When I work as a palliative care physician on my unit in Canada, I never start parenteral nutrition because most of the patients that I see are further along in their cancer journey and closer to dying. So this option or intervention doesn't make sense. But perhaps if you practice as an oncologist or you're seeing a cancer patient early on in their diagnosis, perhaps giving them artificial nutrition to help increase their strength and their overall stability before starting treatment or before doing surgery might make sense. It comes back down to weighing the pros and the cons, the risks and the benefit of every individual case. And this is a scenario where it would be good to ask your other team members, so other specialists, your colleagues, an ethics board if that was necessary, to get feedback on some of your decision making and your thought processes. If there's one thing that I would like you to remember from my talk today, it's this slide. Often patients believe the reason that they are dying is because they are not eating or drinking, when in fact, the reason they are dying is because of their disease. Either it's advanced cancer or advanced organ disease. And these advanced diseases change their physiology. They have no hunger or no thirst, or less hunger and less thirst. They lack the motivation to eat and drink. And even if they were to eat and drink everything, so many calories, they would still continue to lose weight and decline because of their disease. So it's really important to educate the patient and the family that they're not dying because they aren't eating or drinking. They're dying because of their disease first, and this disease is contributing to them eating or drinking less. Sometimes when the patients understand this or their families understand this, they have they're more at peace with the idea of not eating or drinking or not using artificial hydration. So I would just like to wrap up with the case, but before I jump into it, I just want to make sure that there aren't any questions about either the artificial nutrition or artificial hydration.
Any questions? You can type them in the chat. We'll read them out for you.
There will also be an opportunity at the end to ask questions. So maybe just for the interest of time, I will go through the case, and then if there's questions at the end, we can answer those.
Yeah.
So you are working in your hospital setting. You're seeing a 60-year-old man who's coming in with his family. He has advanced esophageal cancer. It was diagnosed a couple of months ago, and he has lost a lot of weight. He presents with symptoms of shortness of breath, some mild pain in his central chest. He kind of points right here. And he also notices lately that he's having more difficulty swallowing solid food, so he's eating a little bit less. His voice is more hoarse. He has tried cancer treatments, chemotherapy, but they've made him very sick and he doesn't want to continue with them. He says that he's lived a good life and he wants to live for as long as possible, but he understands that everyone must die sometime, and when his time comes, he's ready. I'm wondering, would you order any tests, any blood work or any imaging? And then how do you manage his symptoms? He is having some trouble swallowing. Would you consider artificial nutrition, maybe a feeding tube? And just like with Dr. Vallis' cases, there is no right or wrong answer. That's the beauty of medicine, is that it will change based on where you are, who the patient is, and where they are in their journey. All right, so some people are saying yes for any tests. Does anyone have any specific idea of what they might order or want to look at?
The faculty is asking like any specific investigation you wanted to get it done for this patient. You can just type it or put it in the chat. I think Dr. Kandipan has said yes, sir. Yeah, so he says
Okay.
NG feeding.
Potentially some feeding, yeah. Yeah. So I think depending on where you are, for example, Dr. Jonathan explained that I sometimes work up in very remote Canada. And so the places in the north where I work that are remote don't have a lot of resources available. And so to get, for example, an NG feeding tube put in and managed, they would have to travel to a different city. So potentially be away from their family or their care supports. So if that was the scenario, maybe I wouldn't order tests or I wouldn't manage with a feeding tube. So let's say you did a chest x-ray because that was something that was available to you and you thought it might help influence your decision making.
Sorry, ma'am.
Yeah.
There is a chat from Shobika, Dr. Shobika. We need to find out the reason for recent worsening of symptoms and then decide on further plan. Is just that
perfect.
Thought.
Yes, I agree. I think that if we don't know why he's having symptoms, or we think that ordering some investigations may help us to determine the cause of symptoms, then they're appropriate for us to do. So in this case, we haven't seen this patient in a couple months since he was diagnosed. So we're going to do a chest x-ray, which shows a large increase in his cancer and also new metastases in his lungs. So maybe this is why he's short of breath. And also because his esophageal mass is increasing, he is having trouble swallowing. We treat his pain with pain medications. We maybe offer him some steroid medication for swallowing. I think depending on the patient and their preference at this stage, he's walking, he's earlier on in his disease. If he wants to spend a little bit more time living with his family and having quality of life, maybe a feeding tube or artificial nutrition is appropriate for a short amount of time. So let's say you start a feeding tube for a couple of weeks. You can start some steroids to see if that helps allow him to swallow some foods himself orally. And you improve upon these symptoms so he goes home to be with his family, which was his main interest and goal. About a month later, he comes back. So this is the same 60-year-old man with esophageal cancer. He's much weaker and his family says he cannot get out of bed. They also say that he agrees to eat, but he's not actually really eating anything. They're making him all of his favorite foods and they're really trying to feed him at the bedside, but he's just not taking anything. His pain is controlled, but he has new jaundice that they've noticed. The family is very concerned because they feel like he will die of starvation and lack of food. And they want to ask you if you could start an IV to give him food through the IV. What do you think are your options? And what would you do if this was your patient?
Looks the cancer is advanced, probably a metastasis to liver. So it is the multi organs are affecting by the cancer. So we can go for the NG tube option now in this admission?
Yeah, I agree. I think that you'd really have to have a close conversation. This time he's very different. Like you mentioned, he has probably new liver metastases with the jaundice. He's a lot sicker. He sounds and looks like he's probably closer to dying. And so I wonder too, whether or not we would be able to even get an NG tube in if the cancer has increased. And so in this scenario, maybe if it's important to the patient, it's worth a try, but it also might be a scenario where we say, you know, the risk or the harm to the patient is worse. And the patient himself, if he said that he's not hungry and it doesn't bother him, maybe we also need to respect his wishes and not intervene by giving him artificial nutrition. So there's no clear answer. If you had thought I would probably give him artificial nutrition, you might be right. It depends on the patient and it depends on the scenario and your discussion with them. And I'm seeing just in the chat that we need to reassess and control symptoms. Maybe you could try to feed him small, frequent meals, and that even if he can't swallow, maybe he could have some food in his mouth to chew and taste and still enjoy the flavor, which I think is a great option. Perfect. Any other comments or suggestions? I see Dr. Kandipan said pack tube. I'm not familiar with that. Another comment, at the same time, explain to the family and help them understand that his need for food has come down because of the advanced cancer. Excellent. Yes, so back to that slide that I showed earlier that was orange on the background. A lot of family members and patients worry that they will starve to death, and that's the reason that they die, is a lack of food. But in fact, they're dying because of the cancer, and that's causing them to not want to eat or drink. So they won't die because of a lack of food. It's the cancer process that is causing their death. So in the last couple of minutes, I just want to give a brief summary. Unfortunately for us, as the decision makers, we don't have clear evidence to say yes, hydration and nutrition, or no, hydration and nutrition. It is very much an individual decision based on where you are and your resources, and also what the patient's diagnosis is and their prognosis and their journey. If there is potentially a reversible medical condition, I would consider short-term IV hydration or fluids to help reverse that condition if it's what the patient wants. And regardless of the decisions that we make, we need to always constantly reassess the appropriateness of the artificial hydration or nutrition. And I would encourage you to reassess this almost every day, because you've probably seen patients whose clinical status changes day to day. So sometimes the change can be very quick. We always need to weigh the risks and the benefits, the patient's wishes, and then our recommendation as well as the care team. We should also make sure that we're going back to the patient and their decision makers. Sometimes I've run into issues with patients in Canada where the patient actually doesn't care if they're eating or drinking, but the family is wanting them to eat or drink. And so we need clear and respectful communication with the family and the patient to acknowledge the emotions and concerns, but ultimately make sure that we're keeping the patient's interests at the top of our minds while balancing the risks and the benefits. And then we also need to make sure that we're explaining what the natural dying process is and what this looks like for patients with advanced cancer or advanced organ failure. So that's the end of my presentation. I'm happy to take any questions or comments.
So Dr. Jonathan, do you have any comments from the session? By the time the participants have their questions and put them in the chat if they have time.
Yeah, that's great. Thanks so much, Danielle. And I think it's a good topic to add on to our ethics conversation, because there are a lot of ethics involved with feeding and hydration, and it as was talked about, does carry often a lot of emotional weight for families, and there certainly can be very specific cultural practices. So it's good to get a sense of what is meaningful to patients that you're looking after. In Canada, we look after patients that come from cultures from all around the world, and there's very different expectations around feeding and hydration, and there's very different practices around feeding and hydration in different parts of the world. And so what can be standard of care in one country is totally different than in another country. And so it's just trying to get a sense of what patient and family expectations are. But I think, like Danielle spoke about, going back to that balance of what are the potential indications for hydration or nutrition in a patient, and then what are the potential complications, and just treating it like any other medical intervention that you would will guide you reliably through some of those difficult decisions, and hopefully avoid too much harm or side effects to patients. So I think we are kind of out of time, but that was a great discussion today. And Vanila's just reminding us the next session will be on the 21st of July, talking about death and dying, and then another session on opioid availability. So hopefully everybody can join us for that.
So
And
before we
Vanilla,
wind-
I'm
yes.
happy for you to share my presentation and my email address if participants have other questions.
Thank you so much, and we apologize for taking out your time for the previous session. I'm so sorry about that.
It's all good. It worked perfectly. We're
Yeah.
ended on time and I was able to get through my slides. So it was perfect harmony. It worked great.
Yeah, even though it was our first session and meeting you virtually, it was really great session, and even I could learn so many things from your session. Thank you so much. I think at the same time, our participants also have benefited from your session. So if there are no questions, it's already 9 o'clock, and we'll just wind up. I've shared the link for the feedback for this session in the chat box. Please requesting all the participants to please share your valuable feedback. This is very important to us. And the next session will be on 21st of July. So that is on next Wednesday, which is on opioid availability. Again, like we're going to see Dr. Nandini Walak in this session, and Dr. Nandini Walak is going to give an overview, and Dr. Suren will be speaking about Sri Lankan's perspective. And death and dying will be by Dr. Gayatri Palat, who's the head of palliative care here in Hyderabad. See you again. Thank you so much, doctor. And it's a pleasure getting to know you. And thanks you once again.
Thank you so much for having me.
Thank you, and good night, everyone.
Thank you. Thank you.